This is Dr. Bob Dannenhoffer, the Public Health Officer for Douglas County, with another of our COVID conversations. And for more today, we have Sarah Lochner from CLHO with us today. And she's a very special guest, and we'll get a chance to talk to her in just a bit. But for now, let's talk about COVID. And if you have questions about COVID, please send them to us at Facebook questions at douglaspublichealthnetwork.org. So at Facebook questions at douglaspublichealthnetwork.org, a very long title. We'll get those questions. We have two excellent questions today, and we'll get to those as we go through it. As always, we start with COVID at the world level and then move down. At the world level, the number of COVID cases is going up, sadly. We're seeing an increase in number of cases in North America, in Latin America, and increasing number of cases in Europe, and an increasing number of cases in Asia, especially in Japan, New Zealand, and Australia. Singapore has also had quite an increase in cases. Most of this increase in cases, we think, are due to BA2 subvariants or to the BA5 variant. And the BA5 variant is especially concerning. So the BA5 variant is an Omicron variant. It arrived around the same time as the BA1 and BA2, and has most recently really started to take over. We worry about BA5 because BA5's surface is different enough that it evades immunity, either from previous disease or from vaccination. So you're hearing about people who've been previously vaccinated up to date getting the disease, or for people who've had the disease several times. So we now have people who are on their fourth bout of COVID. So this idea that you could somehow develop herd immunity and then get it once and then be done with it is really not turned out to be true. And what we're seeing is people with repeat cases of COVID, and that's really causing a lot of issues. The good news is that people who've gotten some vaccines seem to be much less likely to be hospitalized and much less likely to die, yet they're still getting the disease. And so we do need to worry a little bit about that. When we look at the world, Europe especially is struggling. Europe has relaxed almost all restrictions on gatherings and masks and whatever, and there's really quite a bit of disease. The other areas we're seeing a lot of disease, especially New Zealand and Singapore, they've not had a lot of disease in the past, and they're really struggling now with high numbers of cases. Again, those places, though, that have high levels of vaccination, while they may be seeing a lot of disease, they're not seeing a lot of hospitalizations and deaths, and that is the good news. In the U.S., cases have been flat for many weeks and are now starting to rise again. That is a worry, because we had been flat for a long time, but I think the BA4, BA5, and the BA2 subvariants are really starting to take over now, and we're starting to see a lot more disease really pretty much throughout the country. We're seeing special hotspots in Florida and in the southeastern United States. We're seeing a lot of disease in Alaska and Hawaii, and so that is a worry. Oregon is having a slight uptick in the number of cases, but most concerningly, we're seeing an uptick in the number of hospitalizations, so that this morning we have over 500 people in the hospital. Some have COVID, some are there because they have COVID and other things like they're delivering a baby or have behavioral health, but an increasing percentage are there because of COVID. And what we're seeing in Douglas County, 30 to 40 cases a day, and of those 30 to 40 cases a day, many are pretty sick now, a lot of them on oxygen, some in the ICU and the PCU, suggesting we're really struggling with the amount of disease and the severity of disease. Again, overwhelmingly, the people in the hospital are not up to date on their vaccines. About half of Oregon seniors are up to date on their vaccine, and yet we're seeing overwhelmingly the people in the hospital are not up to date. So again, our best advice is to go ahead and get vaccinated. If you're eligible, get a booster. If you're eligible for a second booster, go ahead and get that. We're especially seeing hospitals struggling. Summertime is usually a quiet time for hospitals. People who worked really hard all winter through the Delta and the Omicron phase are now taking vacations. Many hospitals have open positions and other things that got delayed during Delta and Omicron. So elective surgeries and when we talk about elective surgeries, it means a surgery that doesn't need to be done today, but clearly needs to be done. So people, for example, who need transplants, people who need a hip replacement, people who need a hysterectomy, all of those things are needing to get done because they've been delayed now for almost a year, and they're getting done. So that's filling up the hospitals. Hospitals are also seeing a fair number of sick staff, although most of the hospital staffs are vaccinated. They're seeing people be sick and out with COVID, and then the COVID hospitalization. So the hospitals are really tight. For example, I was in Bend this past weekend, and there was a real concern that the Bend Hospital was nearly at the breaking point, and so this is a worry. And when we look at the number of hospitalizations now at about 500, we're close to where we were during Alpha, which was a fairly big spike. Nowhere near where we were with Delta and Omicron, but it's high. The thought was it would peak this week, but looking at the numbers, it may go up for another couple of weeks until it comes down. In Douglas County, we're kind of stagnant there in the 30s. We do not yet know if the BA5 has arrived in Douglas County. We know it's arrived in much of the rest of the country. We're not getting much sequencing these days, and the last sequences we saw are the BA2 subvariants, but we think the BA5 may be along the way. So again, the best advice is get vaccinated. If you're eligible for a booster, get a booster. If you're eligible for a second booster, get a second booster. If you're sick, please stay home. Again, when we look at cases, people very frequently can point to, I was at work and there was somebody at work and they were sick, and now 3 or 4 days later, I'm sick. So again, if you're sick, please stay home. If you do want to get tested, you can either go to the clinic to get tested or you can do home tests. And if you are positive, you should talk to your doctor about whether an antiviral medicine would be helpful. So the oral antiviral medicine Paxlovid is widely available, many pharmacies here in Douglas County, and really quite effective. We've been trying to find if there's even a single case of somebody who got Paxlovid who needed to be hospitalized, and we can't find one. We do know many anecdotal stories of people who were really quite sick, got the Paxlovid, and within a few days were feeling quite a bit better. So again, if you're sick, stay home. If you're sick, get tested for COVID. If you're positive for COVID, talk to your doctor about getting Paxlovid. Now, one of the questions we came up this week is, well, tell me about these home tests. I got sick last week on Tuesday and I took the home test. It was negative. 2 days later, I was still feeling sick. I went to the doctor. They did a test and it was positive. So is are those home tests worthwhile at all? Well, we're seeing more and more of that story. And I think there's some good explanations. Actually, it turns out the technology that you use for the home test and the technology in the doctor's office are almost identical. But what we are seeing is that for people who test on the first day of illness, it's frequently not positive with the antigen test. And so, yes, you started feeling sick on Tuesday and then went to the doctor on Thursday. They tested you and you're positive. Presumably, if you'd used a home test on Thursday, you'd also find out you were positive, because it takes about a day or two or even 3 sometimes for the home test to turn positive. And then, for some reason, in 5 or 10% of the people, they don't ever turn positive. And that may be that there's just not enough antigen in the nose to go ahead and find it. But overwhelmingly, the home tests are very useful. There are very few false positives. So if you are positive, you almost certainly have COVID. If they're negative, you probably don't have COVID. We'd still recommend you stay home another 2 days and then test again. If after 3 days you've had 2 negative tests and are feeling better, you can go back to work. But testing on the first day really is a problem. The other Facebook question we had is, what is this pandemic going to look like 6 months or a year from now? And as you know, during the entire thing, I always say that predictions are difficult, especially when you ask me to predict the future. But when we look at it, there are a couple of models of what this pandemic could look like in the future. The first one, which is the most hopeful thing, is that it would be a pandemic, it would be past, and then it would be gone. So we certainly know that Ebola came into the country from Africa. It spread a little bit and then went away. SARS came into the country back in 2005. spread mostly from Toronto and down. There were a few cases in the US, and we were able to eradicate SARS, and we were able to eradicate Ebola in the US. That future I do not think is there for COVID for a couple of reasons. One is it's been around long enough that has now mutated into so many different forms. And so there are at least a dozen variants and subvariants of the disease which are circulating in the country. So I do not think we're going to eliminate COVID. In addition, there are a lot of animal reservoirs. Over 20 different species of animals have COVID that circulates in them, including things like mink, deer, rats. And as long as we have mink, deer, and rats, we're not going to be able to eliminate the animal reservoirs when they come back. So elimination, which is always a great goal, I do not think is going to happen with this. I think the best analogy is imagine an influenza. So influenza comes around each year. Some years are bad flu years. Some years are good flu years. Flu causes a fair amount of disability among older people. Pretty much goes away in the summertime in the northern hemisphere, peaks in the southern hemisphere, and then comes back to the northern hemisphere the next winter. So I think the best model for what this looks like is influenza, because with influenza, we have a vaccine, which is moderately effective. We have antiviral disease, which are moderately effective. But even with vaccine and antiviral disease, we still have occasionally people get hospitalized and occasionally people who die from influenza. So I think the best view of what this is going to look like in the future is sort of like influenza, but much more rapidly cycling. So while flu cycles once a year, very predictably bad in the winter, better in the summer, bad in the winter, better in the summer. This is gonna cycle much more frequently, probably 4 or 5 times a year. So when you look at our curve or the curve in South Africa, over the last year, we've had 4 separate big peaks. So it's going to be like flu in that it cycles, but it's going to cycle much more rapidly, probably as much as 4 or 5 times a year, and is going to be much more contagious, so that the peaks are going to be much higher. So the average person with influenza probably gives it to 2 others until they know it's around and people do the things that they do to stop the spread. This one is probably 8 or 10 people get infected from one person who has it. So it's 4 or 5 times more contagious. In addition, for people who get this, the hospitalization rate is far higher than for influenza. So what I say, it's sort of like influenza, but it's going to cycle 4 or 5 times more rapidly. It's going to transmit 4 or 5 times more often, and it's 4 or 5 times more serious if you get it. And so it's going to be like the flu, but I think it's going to be like the flu, but much, much worse. So I think that's what we're looking for in the future. And that's kind of what we saw. So if you remember, we had a big spike in January, February of this year. But come March and April, we were down to almost no cases. And now we're up again in cases. So I think we're going to have a little spike. I think we're probably going to peak over the next few weeks. But then it's going to be there, might get a little bit better in the fall, and they're going to peak again. So this is something that is going to be really hard to predict individually what's going to happen. But I think we're going to see this roller coaster up and down. So what's the best thing we can do to protect ourselves? Well, just like with influenza, it would be get vaccinated, get boosted, stay home if you're sick. And if you do get sick, seek out an antiviral medication, because they really do work. So again, we'll keep following this and see. I think it's gonna. We're not nearly done with this. And for people who suggest it would be endemic. So endemic is a disease which is kind of predictable. Endemic is a disease which is not really disrupting daily life. I don't think we're even close to that yet. There's still quite a bit of disruption in daily life and quite a bit of unpredictability. So I don't think we're in the endemic phase, but I think we may be in a slightly more predictable time where we'll see these ups and downs. So that's what we got for COVID. We'll do this again next week. But today we have a special guest today. So Sarah Lochner is joining us here in Roseburg for the CLHO meeting tomorrow. So Sarah, welcome, and tell us a little bit what CLHO is and why we're meeting here in Roseburg.
Hello. Thank you for having me. Well, CLHO, the acronym is CLHO, is the Oregon Coalition of Local Health Officials. And we are a statewide association comprised of local public health directors from around the state. So Dr. Bob is one of our members. And our purpose is really to advocate for public health programs, policies, and funding to help support the work that local public health does.
Great. And so you're based in the Portland area, but bring together local health officials from all around this big state. So about how many different local health departments are there?
Well, there are actually 33. Most of them are county-based in some shape or fashion, but we do have counties joined together as one unit. And then we also have 2 counties that do not have a local public health department. So there are 36 counties in Oregon and 33 members of CLHO.
Great. So, and tell us why we're meeting here in Roseburg.
Well, every month we have a board meeting, and at your suggestion, actually, we decided to try to rotate throughout the state every quarter and have an in-person meeting or an in-person / hybrid technology meeting so that we could get to know each other's communities a little bit better, see different parts of the state, and also build those person-to-person relationships that are so key to doing this work.
So Sarah and I spent a little time this morning. I was bragging about all the great things that our department has done. And I think you've gotten a chance to see those over the last few months, where we've talked about sexually transmitted infections, monkeypox, all those different things that we're doing here in public health. So Sarah, what are some of the priorities for public health at the current time?
Well, of course, the COVID work continues, as you just talked about extensively. We are not done with this pandemic yet. We are also continuing, to ramp up efforts around monkeypox, of course, and really also looking to the future and trying to build on what we've established both in the past decades, but also as a result of the COVID efforts, really trying to ramp up efforts around other communicable diseases, not just COVID, but sexually transmitted infections and other things. We're looking also to work on climate mitigation efforts, specifically the health effects of different climate events like wildfires, droughts, heat waves, snowpocalypses, and all of those other climate hazards. And also really thinking about equity and how we can do things differently to really lift up and achieve health for folks that are the most vulnerable in our communities.
I know you're also working on workforce. So CLHO put out a fairly landmark study just a few months ago looking at public health workforce in the state, and it's a little grim. So tell us a little bit more about that.
Yes. So CLHO last summer interviewed almost all of our members. So we interviewed 30 of the local public health departments across the state and really got some great detailed information from them about the number of employees they employ, what types of employees, the salaries they're able to offer, and what positions they have open and are having difficulty hiring for. So this report really created a baseline of data from which we can build and add to in the coming years. We intend to update it every 2 years to really look at how the public health workforce either grows or declines over time. And it is our hope that we can utilize this report to help advocate for additional investments in the public health workforce moving forward, and get additional funding from the state legislature for this effort. So one of the things that we found, which we already knew, but the data bears it out, is that local public health has a very difficult time hiring nurses. And a lot of local public health departments still rely on nurses for certain clinical services like reproductive health or immunizations or other clinical services. So we can't compete with the hospital systems or the large health systems that can pay nurses $120 an hour plus a $40,000 signing bonus. That's just not built into the government or non-governmental public health structure. So really moving forward, we have to think about how to either incentivize nurses to come work for local public health, or how to outsource our clinical services to other clinicians or other health systems in the area, so that we can continue to provide those critical services to our communities.
Well, public health is an incredibly satisfying job. So I've had a bunch of different jobs over the years. I think pediatrician and public health officer are two of my favorites. And so it really is a great job, but I really understand how places struggle, especially when they need to recruit nurses to more rural areas. The other project that I know you're working on is this modernization, and you before gave a great description of what the modernization program in the state is. So maybe you can share that with our audience.
Sure. So typically, over the last number of decades, public health has been funded in certain disease buckets. So you have your tuberculosis funding, or you have your reproductive health funding, or you have your tobacco cessation funding. So those funding streams are very siloed, and that money can only be used for that specific purpose. Public health modernization is the effort to move away from that very specific funding stream to a more generalized, flexible funding stream that can serve to support all of those wonderful programs across the board. So it's infrastructure funding for things like communications, which serve all public health programs. Or it's funding for data systems, which again can serve all those public health programs. If you have a real-time data system, you can identify that there's a particular disease in a certain vulnerable community, and you can go and help intervene and stop the spread of that disease. So thinking about those infrastructure pieces that then help create the foundation to support all the wonderful programs that public health does.
And those just-in-time information systems are really important. You'll remember a few weeks ago, we were talking about an increase in overdoses. And there's a system in Oregon called Essence, where we look at things that come into the emergency room, and we start to see a spike in the number of overdoses or heat-related illness or whatever. We can then use that data to respond. So that really is the future. I mean, unlike the internet that knows if you look for something on the internet, you look for garden sprinklers, the next thing you know, everybody's sending you stuff about garden sprinklers. We want to get in public health where if there's an increase in disease like monkeypox or fentanyl overdose or whatever, we can find out about that in nearly real time. So, Sarah, you've been working with us now at CLHO for a year or so. Tell us the kind of work you did before.
Well, I have always been, prior to joining CLHO in November, I have always worked either for elected officials or for the government in some capacity. So prior to CLHO, I was working for Multnomah County in government relations. And as a part of my portfolio there, I worked with Multnomah County's public health department, in addition to several other departments. And then prior to that, I actually worked at the Oregon Health Authority, also in government relations, but I mainly focused on behavioral health while I was there. But there was some overlap with public health in certain topic areas like opioids or alcohol and drug use in general, along with suicide prevention and a couple of other areas. So I got to dip my toes into the public health water starting at OHA. And then before that, I actually worked for the Oregon Senate President, Peter Courtney. And prior to that, I worked for a congressman from Kansas and worked in Washington, D.C. for 5 years.
Well, anyone who knows Peter Courtney knows that he was quite the character.
He still is.
Okay. Well, I can remember his stories, his spellbinding stories. So that's great. Well, Sarah, thank you so much for joining us today. And we're going to welcome all the public health officials here to Douglas County tomorrow for our quarterly meeting. So again, thank you for all that. And thanks to everyone who is watching. And again, if you have questions, please submit them at Facebook questions at douglaspublichealthnetwork.org, and we'll get to them next week. Again, this is Dr. Bob Dannenhoffer, the Public Health Officer of Douglas County. Thank you for joining us.